So I want to open it up for questions now. And I'll start it off with some of our panelists. I'm going to start with Brian. Direct primary care, the concept is you can reduce the number of patients. So you can provide more time with those patients, particularly the ones that are sick. We have a doctor shortage in Georgia, and you addressed this a little bit, but I want you to go back to it. You talk real fast, so you might have missed it. And so really the only concern that I've heard, and we have a bill in Georgia, 28 other states, I believe, have passed direct primary care legislation authorizing it, and it's a very simple 2-page bill. It always passes unanimously. So the Senate took them 2 years, but the Georgia Senate passed it unanimously last year. It went to the House Insurance Committee, passed unanimously. Now it's stuck in rules. So our legislative friends out there in the House, it got this year, January through April, to pass that bill so we can become the 29th state in the country to allow direct primary care. The only concern is this going to worsen the doctor shortage? If the doctors we have, some of them might be treating fewer patients. So how do you answer that?
Yeah, so two things, Kelly. And one thing I'm going to put out there because my pet peeve, sorry y'all. We talk about healthcare and health insurance and we use the same words together. We're not. We always need to think about what we're talking about when we're talking about health insurance reform or healthcare. And they've been melded. So let's be very cognizant of going, healthcare is when you see your doctor, healthcare is when you get a lab, healthcare is when you get imaging. That's healthcare. Health insurance is all this paid-for stuff, right? So just two things to separate. So anyway, physician shortage. So in physicians, we've been, since I was a medical student, which was a long time ago, we were having a push for primary care. It isn't working. You have too many of me and not enough primary care doctors. Why? It's because a primary care doctor sees 2,500 to 3,000 people. I'll try to slow down. They spend 7 minutes with a patient. They spend 22% of their time doing administrative work. They spend 2 hours in front of the computer, 1 hour looking at the patient. They are not very happy with what they're doing. Why would you decide to go into that if you had other options out there? So there's way too many of me and not enough of them. So how do you fix that? You create big movements in medical school going, hey, let's go into primary care. Let's create a primary care initiative. Let's try to find a way to help maybe offset your your medical school costs. It's not working. Why? Because they didn't fix the problem. The problem is they've got to fix how primary care doctors work. You got to make a primary care doctor being able to take care of a few patients. You need to make a primary care doctor feel very valued in their career. You need to make a primary care doctor feel like they're actually helping people rather than triaging people. You fix that problem by fixing the job, not by trying to beg people to go into it. And you start doing that, and you start creating a primary care network that's based around physicians being physicians, taking care of people. You're going to draw people into that space. So you change the dynamics of medical school, and you make primary care what it is. It's supposed to be the foundation of our healthcare system. Right now, it's the red-headed stepchild. And so that's one way that you fix that problem. Two, people are getting out of medicine and primary care because why? They're running around seeing 2,500 to 3,000 patients. They're spending 20% of their time on the computer. They're not taking care of patients. And so you get a lot of primary care doctors to get back to the back end of their career, and they go, you know what, I'm out. I spent enough time doing this. I've done okay in this, and I'm just not going to spend the extra kind of back end of my career continuing to deal with the bureaucracy that's coming down the pipeline on me. I'm out. And that's a really good segment of our population of physicians that we're losing. They know what they're doing. They've been doing this game a while. They need to be teaching the next generation. They don't need to be retiring early. So you do a couple of those things. You fix the disease. Don't just beg people to go ahead and jump into a cesspool that is primary care. Fix the problem, and then you'll actually find that you extend the back end of guys' careers and get more people coming in.
Quick follow-up question. You're a physician, so I might be putting you on the spot, but don't you think that our mid-level providers could be doing a little bit more with physicians, assistants, nurse practitioners, all these areas where we do a good job of training them in Georgia, that they're a lot less expensive than a doctor? Can they not practice to the top of their training?
Right.
I'm not saying they should do surgery.
No, without a doubt. No, I completely agree. My older brother is a nurse practitioner. He'll tell you, I know where my lines are and where my lines aren't. I don't want to cross those lines. But that being said, within medicine, right, we talk about a couple of different aspects of what medicine is. We have precision medicine. You walk into the office with a bladder infection, guess what? It's not really much of a rocket scientist to figure out what's going on. You don't necessarily need to spend that time in front of your primary care physician. That's not intuitive medicine. Intuitive medicine is somebody comes in with a swollen neck and a fever and night sweats and really not sure what's going on. That might require a little bit of a level of higher training in order to kind of parse that. And if you can actually have, again, smaller practice with a nurse practitioner covering some more patients, a physician working intimately together, a healthcare community of pharmacists working together, now you've created a true patient-centered medical home that, again, extends the ability of each of those people to work to the maximal capacity of their abilities. Studies show primary care doctors right now work to 30% of their capacity. They're too busy doing too many other things to actually maximize their utility in our society. So yes, you can extend that by bringing additional people on board, and that's I think that's something that's going to be necessary.
So Russ, in the last 24 hours, we've alluded to it, we've had a couple of announcements from Washington. One is selling insurance across state lines. Of course, Georgia has a law that allows that. I think 2 states have that. Hadn't really taken it up. It's something we think is a good idea. We don't think it's going to, this huge magic bullet. It's an incremental reform. And association health plans, which have been around for a while. So does this mean problem solved, we don't need to do anything? Or what I'm thinking is, maybe some interesting lifelines for some people until we can get our waivers taken care of?
Yeah. Well, association health plans have been around a long time. What you find in most subsets of the general population is that for a period of time, the people that enroll in those systems are healthier than the average population. And the costs are low and the premiums are relatively low. But over time, people get ill. They're still part of the group. As premiums get back to normal because of the increase in costs, people tend to not join, additional people tend not to join that group, and then it sort of rolls down the hill, so to speak. If you had a large group of people that were continually being renewed, more people joining them, that might work. There are very limited situations in where it's worked in the past. I'm not saying it can, I'm just saying it takes a lot more than it sounds like to get it to work. Same way with across state lines. I've had a number of my clients ask me about, how about if I can buy insurance across state lines? I understand coverage in Iowa is a lot cheaper than coverage in Georgia. Why couldn't I buy a policy from Iowa to cover my problems in Georgia? I said, it's no problem as long as you want to go to the doctor in Iowa. That's the way the reimbursement system is structured right now. Now, if you work for one of these companies that were up here, they probably wouldn't have a problem with that. And that's where things are going to happen, I think, more than in the what I would call the huge picture. You're going to see more change on a local basis with things like you're talking about coming from the bottom up, people getting together to solve their problems. I'm going to have, in 2 weeks when open enrollment opens, a lot of people at my door wanting to know what they can do because they can't pay $35,000 a year. In fact, $35,000 a year may be what they're paid. They've got children that they want to take care of. They've got families they want to take care of. It's not easy. So I think local things are going to be a big way to fix things. Things like a direct primary care practice. I'll give you an example. About 2 months ago, Friday night, I had a toothache. Saturday, I had an abscessed tooth. Saturday's not a good time to get an abscessed tooth. I knew I wasn't going to get into a dentist to fix it. I called my primary care doctor on his cell phone because he gave me his cell number a long time ago. I told him what was up. He said, I'll call you. This was Sunday morning when I called him, when it had really gotten bad. He said, I'll text the pharmacist what you need and he'll call you when he can meet you. I got a text in about 15 minutes saying, I'm in church, I'll meet you at the office, I'll meet you at the store in 10 minutes after 12. 10 minutes after 12, I had a prescription. I didn't have to see the doctor, I didn't have to see the pharmacist. That's the way medicine should work for everybody. It's hard if you've got 3,000 or 4,000 patients. I've talked to several direct primary care doctors on the phone that say they've got more like 1,500 patients, maybe 2,000. They are actually seeing 6 to 7 people a day, not what you normally do. I went to get my physical about 3 weeks ago, and I was sitting in the front room for over an hour. Then I went back in the back room and sat for another 20 minutes before the doctor got there, and he was there for 10 minutes. With a medical student, by the way, who didn't seem interested in practicing in a small town like ours. Although I talked to her about that while the doctor wasn't there. Because you've always got to, if you live where I do, you've always got to look for doctors that want to come work there. So I don't know. I think in the big picture we should work toward things like that, but I think you're going to see more of the solutions coming from the bottom up than the top down, at least solutions that work.
Well, that's a great example because there's a story a while ago, back in 2008, there was an individual called DeMonte Driver, 12-year-old boy in Baltimore, I believe, that had an abscessed tooth. And because he was on Medicaid, his mother could not find a dentist that would take him. 3 weeks later, somehow the infection reached his brain. He had to have emergency brain surgery and died 2 weeks later. And you call up on a cell phone and you're meeting him that day. And that shows you what access to care can be, a life and death situation. So before we go to the audience, Ray, what can the states expect money-wise to get, what's on the table for these 1332 waivers? And most importantly, I know our legislators are thinking, how much money are the states going to have to put up? Can we do it without anything? The federal bills, Graham-Cassidy and BCRA, there was no state money involved. And even if it's a small amount of a big number is a big number, and that's money that you're not spending on education or the big pension number we've got to put in this year, or you've got to raise taxes. So states, that puts them in a difficult situation. If it's federal money, that's a whole different ballgame, much easier.
Yeah, so states are approaching it two different ways. So some states are basically doing it all through federal funds that are already going through a state. And so when Alaska did the reinsurance waiver, they were taking the advanced premium tax credits, the APTCs, and the cost-sharing reductions. And then they did an overall state tax, and insurers used that to pay for a little bit of the reinsurance fund. Iowa, on the other hand, said, we're not going to tax ourselves, we're only going to use federal dollars. And you're looking at billions of dollars that could be going to the states and basically reallocated to different people. And then Iowa's also, again, kind of pushing the envelope, because what they're saying is don't just look at the money coming in today, look at how much more money that would be coming in if we don't slow these premium increases, right? So they're saying because the federal government's on the hook for premium subsidies is based on the value of the premiums. If our premiums keep going up 30-40%, federal government's going to be paying a lot more money. And then you're taking a look at other states that are considering, is it only money going to people who are actually enrolled in the individual market eligible for subsidies, or there's arguments to be made that everybody in the state who could potentially be receiving that premium subsidy could be there. So states are being very aggressive and inventive in seeking these sources for dollars. I think what I'd like to see again is for states to be able to combine Medicaid money and some of these advanced premium tax credit subsidies, and being able to actually consolidate under family-based plans, because we know a lot of problems is a children may be on CHIP, the Children's Health Insurance Program, a parent may be on Medicaid, and then maybe somebody else in the family member is getting a subsidies for insurance. So states could have the ability to combine it, access to all that single source funding, and then do a family-based kind of health care plan for those people. So that's what you're looking at. States are experimenting based on what they want to happen, and those are states with good reforms. And on the other hand, you have Vermont, who wanted to pursue federal funds for a single-payer system. So states are being very inventive and creative. And let me just echo what y'all are talking about, the bottom up, because I see it as a race between innovation at the local level to figure out better ways to offer care, outracing kind of top-down control from the federal government that doesn't want to allow a DPC to be able to serve a lot of people, and so I'm optimistic that this administration will start to continue to encourage DPC paid for through Medicaid, a 1332 type program where people that are receiving federal funds, those can be used to pay for some of these arrangements. So it's a big race, and I hope that you guys win.
Getting back to the flexibility, I forgot I mentioned Memorial down in Savannah, along with the grading plan. Their plan was obviously different. They partnered with several counties and rural hospitals in the surrounding area around Savannah and submitted the same type of network because they realized that in Richmond County, they don't have all the resources to offer a comprehensive plan that would meet the muster of the 11 of these 1332 waivers. And so they worked with Memorial to provide that comprehensive plan. So it shows you that there are different parts of the state ought to come up with unique ideas. All right, let's raise the lights. I'm sure we got some good questions out there. Raise your hand. We'll bring a microphone to you.
Kelly, could I mention
Go
something
right
right quick?
While we're microphones are going to our speakers.
So we talked a little bit about high-risk pools and our work on them. Everybody seemed to think high-risk pools were these things that got really expensive and blew up and didn't do things well. I just
1, 2, 3, 4.
It's a book from 2009. This is a comprehensive report of all the high-risk pools that were operating in the country at that time. There were 36 states that had high-risk pools. Most of them working very well, as I said earlier, maybe 32 of them. While current law may not allow those kinds of high-risk pools, there are ways to provide sort of hybrid high-risk pools that would take some of the very large claims off of the insurance company's back, put it into a general fund kind of thing, so that the insurance companies wouldn't be impacted by the few claims that get really big, but would still be paying most of the claims that are under. There's a place in a claims continuum where you go from having 1,500 or 2,000 claims at that level to having 4. So basically you put the high-risk pool bottom at that place, and then you're just paying those 4 or 8 or 10 claims and a smaller group, maybe 100 or 200 or 300 in a state above that rate to keep those huge claims, millions of dollars, from going back into the premium pool where people have to pay for those. So anyway.
All right, questions? Got one right here.
Thank you. State Representative Scott Turner, and I wanted to explore a little bit with Mr. Hederman. He mentioned with 1332 waivers that there are 4 guardrails, and in my notes here it says basically the state would have to provide the same Obamacare benefits. The state would have to offer the same Obamacare cost sharing. We would have to cover the same number of people that would be enrolled in Obamacare. And the 4th one, which is kind of the ringer, right? Basically, we can't add to the national debt. So the federal government, the U.S. Constitution, doesn't have a balanced budget amendment currently. Here in Georgia, we do. That 4th one seems to me like it would be putting Georgia on the hook for any cost overruns that might be experienced by the program. So in effect, we would be unknowingly participating in taking on additional costs that we see skyrocketing in the way of premiums every single year without actually addressing the problem of why those premiums continue to go up. So as a state lawmaker, why in the world would I ever want Georgia, who has the restriction of a balanced budget, to participate in a 1332 waiver when we would be on the hook for any cost overruns?
So, first of all, I think it's the same restriction. Basically, it's kind of like a Medicaid 1115, right, where if the state is on the hook for overall costs, what was unique about this is the Obama administration said it couldn't be over a 5-year period. So what you're seeing is states are saying, let's take a look, and how Iowa's doing it is the tax credit that would be available for their people would only be based on transfers from the federal government, the dollars that are available. So Iowa actually is put in their proposal that I would not be on the hook for it. Instead, you could see a sliding credit based on the amount of money from the federal government. So Iowa built in that safeguard to protect Iowa taxpayers from being on the hook. The second thing is that you could take a look and say, look, if we're doing a flat tax credit, then you have a pretty good idea of what the cost would be. And then you could go back to the federal government and say, look, if more people come enrolled, you can make an argument then saying these people would have been getting higher premiums or higher subsidy assistance from the federal government to make that available. So the states that are pursuing this are taking that into consideration and saying, look, we're only going to go forward with this if we have this guaranteed pool of money from the federal government so states are not on the hook, because that is a very, very valid point. I think one of the big questions I hear a lot is that the same type of coverage from the Affordable Care Act. So how is that defined by the administration? It could be very different from how the Obama administration interpreted it. So it could be basically based on the actuarial value of the benefits, like are you providing a comparable level of, say, 70%, something along those lines. Or, it could be slightly worse, basically saying we want to have more drug coverage, we want to have more maternity care. So again, let states do it. That's why I said that 1332s are not a silver bullet, because you still have that guardrail, which is why some of the federal discussions were being able to create kind of a super waiver for states. But I think, to answer your point, if you take a look at how Iowa basically has gamed it out and written it, they've crafted their waiver that you wouldn't have that open-ended exposure to put Georgia taxpayers on the hook.
I'll answer that one more, if you don't mind, Kelly. So the problem that we have with our thought, right, is that we see things the way they are. It's always hard to see things a little differently. So what we're saying is we're going to take this money from the federal government, no matter however we're paying for health care, and we're going to give it to the same health care system that's high cost, low quality, inaccessible, every touch along the way. The solution is fixing the cost of health care, right? That's the thing we've got to fix. So if we say, how do we fix health care? We create innovative healthcare delivery models that are low cost, high touch, high quality, allow those patients to access a primary care doctor on a regular routine basis, allow them to reach their primary care doctor with a cell phone on Saturday instead of having to go to the ER, or perhaps, God forbid, they get a brain abscess and they end up having to be in the emergency room or operating room and die. Find a way to fix the healthcare problem of accessing healthcare, and you do that by creating a better healthcare delivery model. And so direct pay care, direct primary care, does that in accessing a lower cost, high quality healthcare system. And if you can create, so we're ecosystem change is what we are. I'm not just DPC. We have direct-based contracting for every touch in the outpatient space of healthcare: labs, imaging, pharmaceutical, ambulatory surgery, surgical consultations, specialty consultations. Fix the healthcare delivery system itself from the medicine side, and then guess what? The purchasing power of those dollars go a heck of a lot further. It's both that have to happen. Can't get stuck on just this is how it is, and all we're doing is just paying for the way things are. That's where we solve the problem. That's where Georgia leads, right, the rest of the states. That's how Georgia takes care of its citizenry. That's how Georgia makes its people healthier to become a better workforce. That's how Georgia wins.
And you've seen some experimentation. I was saying there was you're starting to see some states experimenting with Medicaid paying for direct primary care, with the idea that dollars the state is spending. I mean, I don't know about Georgia, but in Ohio, because we expanded Medicaid, it's a huge problem crowding out our other priorities. So again, the idea is tax dollars go further using a direct primary care system where it's cheaper for the state and cheaper for the taxpayers, and more importantly, sometimes the patient gets better care.
Not all.
Yeah.
Always get better care in DPC. I tell people that Medicaid is the pride of the healthcare industry, right? I mean, you could have Medicaid in your pocket, but not a whole lot of physicians take Medicaid. It doesn't do you a whole heck of a lot of good if a doc doesn't take care of you. And then if you're one of 3,000 people that your doctor's trying to run around and take care of, you're not going to get that great care. Do both. Drop the price of care and make better care.
Perfect example, our ABD population in Medicaid, which is the sickest group, disabled individuals, it's still fee for service. So those are the ones that are having a hard time finding a doctor. And direct primary care would be a great solution for them. Question? Over here?
Kelly, Sharon Cooper, Representative Sharon Cooper, Chair of the Health Committee, and a former nursing professor. So I tell you that because I wanted to say I know what I'm talking about. First of all, when you're talking, and it's mainly to you, and it goes to our whole problem in the healthcare system, you're talking about the mid-levels. Well, the mid-levels, the nurse practitioners and the PAs, are not in the areas where we need them, just like physicians. We are a rural state. They are not in the rural areas. We have a workplace place. I have a map on the back of my office door, and it shows where the physicians are, where the PAs are, and where the nurse practitioners are. They're not in rural areas. They'll tell you they want to go out and treat this population, but they're not there. And it's the same reason there's not physicians in many ways. They can't make a living. They have a spouse that needs to work, and that spouse can't find a job in Ocala, Georgia. So we have that problem. So, how do we solve that? The other problem is I want you to tell me I hear all the time, we should let our mid-levels practice to their full ability. Well, what is that? The only thing our nurse practitioners can't do now is work independently in our PAs, and they don't give Schedule IIs opioids. Would you have them give opioids in the middle of a terrible crisis? And the nurse practitioners can't order the really, really, really expensive x-rays like CT scans and things. They can do it if it's life-threatening. And there's reasons for those. So what do they want to do? What are you saying is to the fullest of their ability? And the other thing is, they're not coming out of school trained well. And so like Dr. Hill said, if they had like an internship of a year or so to go out and work more independently, if they were in the areas, but the nurse practitioners, not the PAs, the nurse practitioners come down to the Capitol and say they are better than physicians. There's something about knowing who you are. I mean, these are major problems that we face, and yet we have, the programs that are being offered more and more in nursing school. It's online experience and less clinical experience. And your hospital administrators of nursing will tell you that we are turning out nurses in this state that cannot function independently on a med-surg floor. So I think when you start talking about using extenders more, you also need to bring up the problems that they're having and look at it realistically. And I don't know where there's a question in that. But it's really a problem that I have in being tired of listening people talking about using mid-levels, and they don't know the whole scope of the problem. Sorry. No.
I'll do a quick question.
I want to ask Sharon's question.
Can I answer Sharon's question? And that's awesome, Sharon. So I think it's time for us to come together as a healthcare system and physicians and nurse practitioners and stop fighting over silliness, right? Our job is to take care of people. And so when we see, in our offices and how we have our offices set up, we actually limit our patient panels to 700 patients that a primary care doctor takes care of. If we bring a nurse practitioner on, we extend it to about 1,100 to 1,200. An average physician practice is 3,000 people, with a nurse practitioner carrying probably another 1,500 patients on top of that. We create a relationship between the physician and the patient and the nurse practitioner. It's a team. It's a team working together. We have a health and wellness coach in the office. It's a team. It's everybody focusing on taking care of the person in front of you. It's not going, hey, I got to fight for my NP to get my NP to be able to write this prescription. And the reason that's so much in today's healthcare system is everybody's so distracted. We're too busy looking at insurance and all the regulations and the worries instead of going, hey, we can get rid of all that stuff and focus on the patient and spend our resources there as a team. And so I don't worry too much about, and that's why I don't fight down at the Capitol too much about, the trying to limit patients or people's ability to go, hey, I can write this, I can write that. I go, let's just create a team that actually is focused around the individual and the patient and create a patient-centered medical home around a limited patient panel focused on them. And as far as the community and getting out into the rural communities, right, huge problem out there. Big problem from the physician side, they'll tell you, is payer mix. Right? I'm not going to go out into a place where I have a terrible payer mix. My payer mix goes away when you create a membership-based model for primary care. I have a fixed payment model that we do. We actually match our product of primary care. We can do it with the business. You can actually, we have an insurance that doesn't mess with us, but actually is a lower cost insurance product that allows us to go into the marketplace of a rural community and say, hey, this is what our primary care doctors, we know it's a fixed payment model, we know what our physicians are going to get paid, and we can actually pay our primary care doctors pretty well because we just popped the bubble of all the excess costs in healthcare that are administrative. I get rid of those 10 administrators that stood up. There's a lot of excess capital that's available to be spent on actually taking care of people. So we got to pop the bubble. That fixes the problem.
I opened a little can of worms there, didn't I? Russ, real quickly.
One of the things that would help a lot. There are several programs in Georgia that encourage physicians to practice in rural areas. I'm from a rural area, so I'm right on board on this. But there's several programs that encourage doctors to practice in rural areas. They pay their medical school bills. They do things like that. there are not any programs for PAs. There are not any programs for nurse practitioners. We need to expand those programs to PAs and nurse practitioners so that they get exposed to rural areas so they know we're not all that bad. And they can come treat us. We'll be nice to them, you know. Yeah.
Senator?
I was afraid to follow Sharon. I have a couple of questions. First one is, when we talk about the individual market, that's what we're talking about here, not the group market, so everybody's on the same page. How many people are we talking about in Georgia, number one? Number two, when we talk about the individual market, and I like the idea of direct primary care, there's only one problem. In the individual market, I don't know if you can buy catastrophe coverage above that. And that's a problem there too. And the third point is this. It gets back to what the doctor said. We're not talking about the cost, folks. When people go in to see the doctor today, they run all these additional tests because of defensive medicine. We're not talking about tort reform here, okay? Well, they're not talking about it in Washington because of the lobbyists. Let's talk about getting to the root cause here. Because, you know, all we're doing here is taking money and still paying the insurance companies. Mm-hmm. That's all we're doing here. That doesn't answer the problem. It doesn't solve the problem. The problem is cost. They're out of sight. They're unbelievable. People can't afford it. When he's talking $3,000 a month, are you kidding me? It's more than these people's mortgages. I mean, we've got a crisis here. And, you know, I like the ideas you have, Kelly, and all that. But we also got to deal with the costs here, and we can't lose sight of that. Because last time I checked, my friends in the insurance industry, of which I was a part for 40 years, they got pretty good, healthy balance sheets.
Yes.
Well, I would echo, and we're out of time, right? One quick response, right?
Yeah, I would agree. Let me one small defense of insurance companies mostly is that because they are now being mandated to cover, and they can no longer do any type of risk analysis. So you take a look at a lot of these regulations, and there's some great work come out of my colleagues saying when you mandate all these benefits, right? Like I hear a lot about, you know, the free birth control that came up. That comes out of higher premiums, and that's why these prices are so unaffordable. So being able, anything we can do, resting down what government is requiring insurers to offer, that's going to help driving down premiums. Sorry.
The third of the tests that have to be taken right now.
Oh, yeah. Yep.
That, you talk about driving costs. Yep. I bet that, you know, even a primary doctor, but you go in to see a specialist, and they got to go through this root canal thing situation in order to treat you. It's absurd.
Yep.
And they know better, but their hands are trying.
Let medicine be medicine.
Yep.
I said, guys, let medicine be medicine. We'll drive down the cost of care. Let insurance be the way you pay for health care, right?
One thing we learned about cost, I think one, primary care, investing in that is one. Let's make sure employers are at the table. Let's get our data and analyze so we know what we're doing and we know if it's going to work. Thank you all very much. Thank you to our panel. And we'll be back in about 10 minutes to get us set for lunch.